So this is going to be a good day. If just wondering if there's a geo that's going to be coming in at some point during this hour. So if I get really strange, that's probably why. Middle Sylvester gave me the weirdest order I've ever gotten in my career this morning. He said, no Yoda hands today in the geo.
I think that would have been the perfect time.
Yeah.
I know, that's what he said. He said, I would tell you to just be yourself, but don't do that. Be normal. Okay. So, whatever, we got it. So, okay, whew. Here we go to the day. Kids for the day. So, let's warm them up. Okay, what age do you get a screening dyslipidemia panel for all children? 9 to 11 and 17 to 21. Nice. At what weight can you give neonates immunizations? 2,000 grams, 2 kilograms. And what is that immunization at birth? Hep B. Good job. If a child has a true anaphylactic egg allergy, can he or she get a flu shot? Yes. What temperature should your water heater be for all children? At what age do you need to avoid fluoride toothpaste until? You don't have to. Yeah, fluoride. How much do you give under 2? A rice grain. Whatever that means. Okay. At what age can an infant should an infant be able to sit up? 6 months. How old to babble? 6. Babble has 6 letters. At what age should you be able to put 2 words together? 2. At what age should you be able to be fully understandable to a stranger? 4. If you're concerned about a speech delay, what 2 specialists do you refer to and which one's first? Audiology and speech therapy. Good job. You guys are killing me. It's so good. Okay, so where we're going. Neonates, we talked about, we're halfway through with block 1. So you officially have half of block 1 done. So we talked about the neonates, then what can go wrong. Then we had the well child, and now today we're talking basically, okay, you've done this well child exam. What happens when that goes wrong? So what are some of those things that you might find on exam as you're going along? And then some congenital syndromes. The PANTS loves congenital syndromes because it is predictable in the phenotype and the way it looks. So we're going to give you some of the most high yield ones so that you're ready for PANTS. And talk about how many you may or may not see in real life. So as always, the beginning of that, it's about 10% of that health maintenance on this. So we'll jump in. So what we are talking about, the first thing you do this well visit, and the first thing that you might come across is you did those growth charts, and you find that somebody has really not grown, and growth, again, remembering their body is changing size, they're not meeting their expectation for growth. And so this can be from a whole lot of different factors. Maybe this was the family that only gave breakfast, lunch, and dinner. Maybe this was a family who there is some genetic anomalies going on. There can be all kinds of reasons, but by definition, if you are not meeting your growth requirements, you would be classified as failure to thrive. Okay, so this is again for growth, not development. You cannot say you have failure to thrive because you are in your senior semester of IPAP. Nobody has failure to thrive here. You're all thriving. You're doing great. Has anyone told you that lately? You guys are doing really good. You guys are doing really, really good. You're so good. You're doing so good. I'll just start telling you guys every day. You're doing so good. So about 2/3 of the time, when somebody is not growing appropriately and they are classified in the definition of failure to thrive, the cause is an inorganic cause, a neglect, an abuse, not knowing. It's breakfast, lunch, and dinner, not knowing the caloric requirements for these kiddos. About 1/3 of the time, you will find some sort of organic or lab value cause. And so we'll talk about some of those and how you evaluate those. So the definition then, and you will need to be able to pick this out on a test, which is going to be confusing with what I say next. It is either if the child is below the 3rd or the 5th percentile. And you say, why is that? Well, because we in the pediatrics community cannot decide which way we want to do. So do you remember what your normal BMI percentage was and normal weight percentage was? 5 to 85, right? So if we call that normal, then less than 5 should be considered failure to thrive, right? However, mathematically, that is not how 2 standard deviations works. So 2 standard deviations will put you at the 3rd percentile. So some people will go by the percentiles for standard deviations, and some will say, no, we need to stay consistent with the BMI and weight normal percentiles. So there's no consensus. So what that means is that if I have a test question on it, I will give you something very obvious. It is the 1st percentile. It is the 10th percentile. I'm not going to give you the 4th percentile. Okay, I'll just tell you that. So that would be first thing, is your weight specifically is below the 3rd or the 5th percentile. Number 2 is that you are crossing 2 of those lines on the growth chart. So you crossed 1, we're watching, you crossed 2, now you're across 2 major percentile lines on your growth chart. And then the 3rd one, the one we probably use the least, is that your height to length is less than 80% of the mean. So we probably use that one the least. This would be another area that you adjust for prematurity. So areas that you adjust, remember the ages and stages questionnaire, you adjust if they're less than 36 weeks. For your growth charts, you adjust if they're premature. Do you adjust timing for shots though?
No.
No. So that is one. You do not adjust shots, you do for growth and development. So if you're looking at some of those causes, one of the, in general, no matter what it's from, organic or inorganic, you have an insufficient caloric intake to meet your cellular needs. Said this in one of the first lectures, that growth is a luxury of excess calories. And so if you do not have those excess calories, you will not grow. Makes sense. So number 1, you might not have enough intake. Think the breakfast, lunch, and dinner family. Number 2, you might not be absorbing it correctly. Think about celiac or Crohn's disease. And number 3, you might have an increased need for calories. Think about a congenital heart, where they are needing more calories to sustain the oxygen output. Even amongst that type, there are priorities that your brain will and your body will do to maintain. So there are going to be 3 severity levels of how bad your failure to thrive is. So what do you think is going to be maintained absolutely last? What organ is the most important organ?
Brain.
Your brain. So your head circumference is going to be the very last thing that is maintained for all of these. Next thing in order of importance is going to be the length or your height, your linear growth, and then finally your weight. So the first thing that's going to drop off in type 1, the wasting type, is while it's all severe, the least severe of the severe is going to be your wasting type, and that is when your weight is affected only. So now you have these really scrawny little kids who are really long and have maintained heads. And that's type 1. So this one is an example probably. Yeah, that might be a type 2. But see, the head is still large compared to the rest of the body. You can use that as an example of type 1. Type 2 is when your weight is affected and now your linear growth is affected. So this would be either a really long standing time where it wasn't recognized, or you can have some genetic causes. But most of the time, think about type 2 as a really long standing chronic malnutrition status. The head is still maintained. So now you have a really skinny, really kind of shortened, really long, large head for a child with type 2. And then type 3, everything is affected. So your weight, your length, and your head are affected. So it's very symmetric at that point. So either very, very long standing, most likely with type 3, you have some sort of chromosomal or genetic anomaly going on now. This would be an example of this. So how do we know this is a boy's chart or a girl's chart?
Boys.
It's a boy's chart, okay? The top child, what percentile is their growth been in? 75th, yes. So the top child has been always tracking along that 75th percentile. Pediatrics said tracking before it was a military thing. The bottom child, where did they start? What percentile did they start when they were born? Yeah, they started about the 25th-ish percentile. And they started to go up. And at month 2, they were still around that 25th percentile. About month 4, you start to see they're still growing, but it's starting to level off, right? And then at month, what is that? Month 5, we have virtually no growth, and now we've crossed over 2 percentile lines. So your diagnosis of failure to thrive should have actually been made at this marker. Where this child was, it crossed over 1 line, and now over 2 lines. So this is where your diagnosis should have been made. They should not have continued. Okay? So that would be an example of what a failure to thrive chart would look like. As soon as you give them the calories, they jump right back up. But notice, when they jump back up, the child didn't jump back up to the 25th percentile. They had lost some of that growth potential. They jumped back up to the 9th percentile. Yes, ma'am?
Does that mean for like the rest of their life that they've been affected for their growth potential?
Potentially. Depends on how long and how long standing it was. So this child, potentially because they lost all of those 6 months to 8 months in there, but it's one of those you'll never really know, right? You never know what their potential could have been, so difficult to say for certain. But that's how you would read that. Yes, ma'am?
Ma'am, can you show over here?
Oh, yeah, so we started in the 25th percentile. So this is where we start, the trajectory is slowing down, and now here is where you would have made that diagnosis because you crossed 1 line here and then the 2nd line here. So right there is your definition of failure to thrive. None of these should have happened. Make sense?
Great, thank you.
In theory, when you are all out there as astute PAs taking care of children, that won't happen. Right?
Right.
Correct. Yes. Is it still dawn for you guys too? Okay. So then what are you going to do? If you had a chart like this, and let's say you didn't know that it was this, you didn't have that recovery, and you just get that flattened chart, and you are starting to think, oh no, what do I do with this child? Do I do inpatient? Do I do outpatient? Do I call Dr. Klein? Do I run away from this child and pick up a different chart? What do I do? Your question will be, do I need to do outpatient or inpatient? Do I need to hospitalize or not? And that's going to be a big differentiating point where you will have to use your provider brain for some of these clinical decision making. Most of the time, right, this took a while. This wasn't overnight. So most of the time you can do outpatient for this. It's fine, most of the time. When would it not be okay? So number 1, if you think that this is so severe that their vital signs are being affected, the child is unable to stay conscious, the child is, there's a look. And so when you'll see it, I hope you don't see it, but you just kind of lay there floppy, like, help me, right? So if they give you some of those looks, that would be an indication to do that. If you look and you're like, sick, not sick, right? That would be an indication. Usually if they've been more than 2 periods of their growth, that is usually considered severe. So right, let's use this child again. This child at the 2-month mark was okay, but now by the time we got here to the 7-month, we missed the 4-month and the 6-month. So we've missed 2 growth periods. That will put you in that severe category. If you had some underlying diagnosis that was going to require a significant diagnostic workup, let's say we need to do an EEG, and we need to do an endoscopy, and we need to do a colonoscopy, and we don't want to have the child sedated multiple times over multiple appointments. Sometimes we'll hospitalize to expedite a workup for that. And then if there's any safety concerns, if you thought that some of these growth charts were due to abuse or neglect, that would be another indication to do inpatient therapy. Or, the last one, the one to watch out for, because the PANF loves this one, is if you've tried outpatient, they have come for all of their follow-ups, they've gone to the dietitians, they've done all the things, and they have failed outpatient, then inpatient is going to be what you would do for those. Reason being is you have strict control over their eyes, nose, their input, and their output. So what are you going to do for that? What are your options if you're in the hospital? So option 1, now you've hospitalized this child, you're controlling what goes in, and then you're calculating what comes out. So option 1 is they feed fine, and they gain weight. And at that point, you're starting to think, okay, what is going on at home? Is this a breakfast, lunch, and dinner family? Is this, they have food insecurity? What is going on with the feeding patterns and feeding availability? Option 2, they feed just fine, but they still don't gain any weight in the hospital. And at that point, those are your organic causes, usually. Those are when you're starting to see, okay, so they are intaking it fine, it's just not absorbing. Do we have some sort of metabolic cause? Do we have some sort of absorption cause? Is there something going on that they cannot use the calories that they are appropriately intaking? And then option 3, they feed very poorly in the hospital and they don't gain any weight. So is there some sort of functionality issue, suck, swallow, breathe mechanism that they are not able to do, frequent vomiting or regurgitation, something like that. So kind of some different options, and then your workup will follow as such. So your history is going to be extensive. You're going to be a detective in this, so you're trying to figure out which one of these categories is it falling in. So significant histories all the way around. What's new? Are we just PCS? Do we have a new caretaker in the home? Has grandma moved in? What was birth history like? What was mom's history like? Other children. So an extensive history. Very careful growth charts, full exam. This would then be your differential. So some of the time, what we've heard as instructors is that differentials can be a little bit harder as you're learning them. So this is basically what your differential for those organic causes would be. So remember, this is only that 1/3, 2/3 of them are inorganic. 1/3 of the time, these are things that you would see. So if you started seeing a child who was having some of these upper GI, spitting, vomiting, rumination, no, I don't want food, you're really starting to think there's something in that upper GI or hint region. Reflux, EOE, something to that effect going on. Versus lower bowel, so diarrhea or fatty stools. If you see fatty stools anywhere on any kind of test, it's cystic fibrosis. Right, it's looking for pancreatic insufficiency. So greasy, fatty stools is the PANT's way of trying to let you know their pancreatic enzymes can't break things down, and so they're looking, why can't a child have these pancreatic enzymes, and it's from cystic fibrosis, like 99% of the time. You could have some sort of, again, hints, a snoring, enlarged tonsils, something up in there going on that could be a reason for this. Pulmonary infections are going to be one. Any infections can do this. Long-standing infections, so HIV should always be on that differential, and then travel would be kind of your outlier on there. Have I told you about my favorite word, consider, yet? So consider is my favorite word for medical charting, and I'll tell you why. My last job was in risk management, and if you put consider, it's very hard to come at any provider. So you can consider anything, and thus you have not anchored to that, but you have not thought about it. Right? So it's this perfect word for risk management as a provider. So I use consider all the time. So these are labs to consider for your workup. So from your history and your physical, this does not mean this is your workup for failure to thrive. This means these are those labs to start thinking about depending on your history. To say which one do I actually think will matter and will change what I will do with this patient. So a CBC is obviously going to look at, what are your cell lines doing? Do we have an underlying cancer, and that's the reason that this child is using up all these extra calories? Do we have an anemia that needs an iron panel with it too? Basically anything infectious. So do I need any kind of cultures, urine cultures, stool cultures, HIV testing for any of those underlying infectious causes? Or am I losing protein through the urine and I need a UA? Lead can always be tricky with things, so lead. And when do we do that routine lead screening? 12 with lead draw. 12 months. When are your questions? 6 months to 6 years. Good. Thyroid, because thyroid can mimic anything for cellular differentiation. So your TSH. If you really think that it is a malabsorptive reason, celiac is going to be what you're going to get. And then if you're really in that type 3, you're thinking this is symmetric, this is overall, then do I need to have genetics and a chromosomal analysis? So these are things to consider, not necessarily that you will get for every single child. Your outpatient management then is going to make sure you are adjusting for caloric intake. I use the family over and over. They just had to be taught, oh, you feed every 2 to 3 hours. These are your volumes that you need to be doing and how to increase that as the child gets older. We see these children very, very often in clinic. So do you remember how much a new baby is going to gain roughly a day? 1 ounce. 1 ounce, right? So in a week, you should see a baby be able to come back gaining 7 ounces, right? So you have a frequent amount. So there's a lot of these kids that I would see on a Monday and then a Thursday, and then the next Monday and a Thursday, because we're plotting them and we're watching to make sure that they are meeting those calorie requirements. Dietitians are your friends. If you love pediatric nutrition, it's super interesting. I have giant books that we could calculate caloric intake for children, or you could send them to the dietitian who will calculate that for you. So you could do either way. And then hospitalization, definitely if you need that. Your caloric intake is typically about 1.5 times what otherwise you would need as a normal child to be able to do that catch-up growth. And then supplementing anything that they might have lost in that time frame, vitamins, minerals, things like that. Big team approach. And I want to plug, there's some of these therapists that you don't maybe hear about in the adult world. Everyone's heard about speech therapy, occupational therapy, and physical therapy. But there's a specific therapy called feeding therapy that is specific types of speech therapists that work with children with failure to thrive to make sure they can do the suck, swallow, breathe motion. So let's check on some things. So we're trying to wake up. You've been following a child since birth. They have concerns with the growth chart trends. Which of the following would classify as a diagnosis of failure to thrive for a child? Is it the child who has a 3rd percentile for length? Is it a child whose weight is at the 85th percentile mean weight for height? Median weight for height? Child's length has increased and crossed 1 percentile since the last well visit. Child's in the 3rd percentile for weight, or the child's weight percentile has not changed from the last visit.
Percentile for weight?
D. You're correct. The 3rd for weight. So it is not necessarily length. You start with weight. So that's why A is wrong. Well, how would B be correct? Correct. Yeah, if it was less than the 80th percentile. So if I had said 79th percentile, correct. C is just wrong. If it was decreased 2 percentiles. And then E could be right, potentially, depending on how many percentiles it changed and how long that time frame was. So this is why this question is not a real life question. Okay, so that was your failure to thrive stuff. Now we get into some of your common congenital disorders. And these ones, well, we'll just talk about them now. Lots of them. These are the ones specifically we're going to talk about, and you're thinking, why these ones? Why did she pick these ones? Are these just her favorite ones? No, these are the ones that are on your PANTS blueprint. So these are the ones that the PANTS says you need to know and be able to differentiate about. So, when we're talking about this and thinking about this in context, you're going to go out and you're going to do your pediatrics rotation, and you're probably going to see a couple of things with different children, and the pediatrician or whoever you're working with is going to say, wow, I've never even seen this, and you're going to think, how long have they been practicing? Which is fine, but here's why. So, out of 100 births, about 2 have some sort of genetic or chromosomal anomaly going on, so 2%. However, that 2% makes up about 50% of all of pediatric hospitalizations and our visits. So we see these children proportionally a whole lot more. Okay, so pediatrics is basically going to be 2 camps. You're going to see normal, well, healthy, happy children that you're like, well visit, screening, yep, normal. And then you're going to have this whole categorization that's like, that's crazy, I've never seen this. This is the 1 in a billion child, and we see them all the time. Right? So there's really 2 camps of pediatrics that most kids will fall into, and that is why. So if you're on your rotation and you're like, I can't believe I saw whatever, let me know, because I'm just curious of what you guys are seeing. As a reminder, to get on the same page, we are going to talk about some that are autosomal dominant, so 50-50, boys, girls, autosomal recessive, some of those, 1 in 4, and then your X-linked ones. If you ever see a specific time where someone tells you it's a girl and they have a family history of this, they're trying to tell you it's not X-linked. So specific with that. So as we get into the specific syndromes, we're going to talk about this. Please do not memorize these epidemiologic numbers. We'll say it again, this is not something that I am going to waste a test question on. How many babies are born with Down syndrome each year? Like, what a waste of a test question. What I'm trying to do when I put the epidemiology in for any of these lectures is give you context. How many children might you expect to see with this versus that? How many visits can you expect with that? So this is just context. Please do not spend your study time learning these numbers. So we're going to talk about Down syndrome first out of the gate. So if you, quick review here from one of these, what would be your NIPIT test that will look for Down syndrome? Your quad screen. What is in your quad screen? Try somebody use which one? 21, 18, 13. And then what's the spina bifida one? Alpha fetoprotein. Good. What if you had the harmony screen? What's that? What does that look at? Yep, the sex of the child. Okay, good. Remember, Down syndrome is going to be the most common, because that again is the smallest of the chromosomes, so the smallest amount of genetic material. That's why we see it the most of any of the trisomies. 3 copies of chromosome 21. So if you think about that and all of the things that we're going to see as a result of that, it's because you have 3 copies of this. So you have extra of some things where that's going to cause the problem. And remember, way back to probably some prereq you did, the increased maternal age is going to be one of the reasons that you see this. Remember those way back in the cobwebs of your mind, mitosis, meiosis? This is because mom's eggs will halt at meiosis 2. And they will sit at meiosis 2 until they have that final disjunction at the time when the egg is released. So if that process, if those eggs just sit there longer and longer and longer, the chance that it's going to pull apart perfectly goes down. So you have non-disjunction. So that is one of the reasons. The most common reason. So every child should have a chromosomal analysis to make sure that you are actually seeing these 3 copies and make sure that it is not some other form of genetic inheritance here. The reason I put this in here is that the PANCE loves to trick you on this question. So if you are looking at rates of Down syndrome, you could be looking, the question usually asks something to the effect of what age group has the most likely, or is most likely to have a child born with Down syndrome. And everything in you wants to pick over age 45, but that is not the case. What they're trying to get you to see is that in the age 25-year-olds just have more babies. Because they have more babies, they will have more babies with Down syndrome. Right? So they're trying to trick you there. Versus if you did baby for baby, you would see more in the 45 and up population. So that's just one of the, just read questions carefully. I'm not going to put that one on there, but I've seen a question like that on the standardized testing, so I just wanted you to have that so you read it carefully. But this is going to be one of the things we see, and part of any kind of prenatal counseling that you would do for an older mother would be talking about the increased chance of having a non-disjunction or having a baby with Down syndrome for these reasons. So what is this going to look like? So these are the ones that I need you to know to be able to pick out these words between the different types of genetic syndromes, okay? So babies that come out with Down syndrome are very hypotonic. So these babies have a head lag. They will often have a decreased Moro reflex. What's the other name for a Moro reflex? The startle reflex, good. Their heads in general will be very small, which should make the face characteristics make sense a little bit more. So if they have a small head, then everything in some ways is a little bit compressed in the way of how it's fitting. So the line at the edge of your eyes here is your palpebral fissures, and so you have an up-slanting palpebral fissures. That's one of the things. You have epicanthal folds, so kind of the inside of your eyelid here. You have in prominence of those epicanthal folds. Mid-face hypoplasia, so flattening of the nasal bridge, so it kind of looks like running into a wall, so kind of flattening of the nose, that mid-face hypoplasia. Small and irregular ears. So the ears themselves can be low set. Remember we went from the palpebral fissure to the back of the occiput. You should intersect the ear. You can have very low set and very small ears. The one thing that didn't get the memo for we have a smaller head was the tongue. So the tongue is a very normal sized tongue, but it looks like a very large tongue compared to the rest of the head. So it looks like the tongue just doesn't quite fit in the mouth. So it's considered macroglossia, but it's actually the right size, and the rest of the head is small, if that makes sense. So we still call it macroglossia, but that's kind of why. Some of the other extremity features, and again, these features you can see in normal humans. You just see it more increased in people with Down syndrome. So the first one would be a single transverse palmar crease. So you look down at your hands, several of these genetic syndromes will have specific things with the creases of their hand. So transverse single palmar crease is one of the things. You guys are all laughing. I told a really embarrassing story in one of the classes a couple times ago, and now I feel like I have to tell it in all of them. So I feel like I'm going to. Why? Because it's 8 a.m. I said I wasn't going to do it. But, so my point in that it can be a normal phenotype, so you can see the short fingers, you can see a widened space, you can see a widened space between the toes, all those things. But I was a medical student, I was learning all of these things, and I went out on a date with a guy, and he had a single transverse palmar crease, and that was all I could see. Like, I don't remember his name, I don't remember what we talked about, I never saw him again, but that's all I remember was the single transverse palmar crease. So anyway, there you go, you remember that. Other things that you're going to see, we're going to talk about all of these in detail, so this is kind of a review slide. So first thing that you're going to see, because of some of that small head, another thing that can be very, very small is the external auditory canals. The small canals is going to be poorer conduction, but also the nerve is going to be affected. So the nerve inside of your eighth cranial nerve is going to result in some sensory neural hearing loss. So most of these children will have some sort of either fluid buildup, conductive hearing loss, or sensory neural hearing loss. Probably sensory neural is the most common there that we will see. So because they have some flattening of the ears as well, since they're lower ears, so their canal is a little bit more flat, they're going to get increased and frequent ear infections that can produce scarring over time as well. So ears are big, and these are ones to make sure they are hooked in with an audiologist ASAP. These are a lot of other things that we see. Brush field spots, you can kind of see these gray pigmented spots on the outer part of the iris. Pathognomonic with that. You see cataracts. So this one's super interesting. I'm going to nerd out on you guys here for a minute. The precursor for beta amyloid is on chromosome 21. And so if you have a precursor that now has 3 copies, you're going to make significantly more of that downstream product, right? So you have increased beta amyloid plaques. So you're going to have this increase in beta amyloid is going to make early cataracts. It's also going to increase your risk of Alzheimer's. So you'll see early Alzheimer's in people with Down syndrome because they have 3 of these precursors. You have an ectopic lens that can happen with the eye. You can also have some increased refractive errors. The shape of the cornea is increasingly steep. There's an embryologic process called esommetropia that forms that shape of the cornea that doesn't happen well when you do not have the right precursors. So you have increased refractive errors that are going to then cause some increased strabismus. So a lot going on with the eyes with kiddos with Down syndrome. And so eyes and ears are going to be specific things to watch out for these kiddos, if for nothing else than for their quality of life, but for much more than that too. Another thing that will go wrong sometimes will be the endocardial cushion defects. So endocardium, the inside of the heart, when you have 3 copies of chromosome 21, it increases the adhesivity, and so they're kind of sticky cells, so they don't pull apart and then kind of glue well during the embryologic process. And so you have kind of missing parts of some of those septums. So you have an increased risk of an ASD, of a VSD, because the endocardial cushions were kind of extra sticky. It's kind of the way to think about that. But the words that you need to associate are the endocardial cushion defects and then an ASD, VSD. But those are some of the reasons why. When that happens, if that is not recognized, thinking back to cardiology, if you have a hole in the heart, an ASD or a VSD, you are going to have oxygenated blood that is going to shunt back to that right side and recirculate through the lungs. We just got oxygenated, now we're going to go back through the hole and we're going to go do it again. So that over-circulation is eventually going to cause pulmonary hypertension because the pulmonary vasculature is going to say, I just oxygenated you, we're not doing this again. Clamp down, and that increase of the pressure is going to put that back pressure on the right side of the heart. Thus, you end up with unhis and minors over time. So that is what you are trying to avoid for these children because they're at such higher risk of having an ASD or a VSD. Sometimes you have that excess amount of genetic material. Sometimes it doesn't quite seem like it has enough. So duodenal atresia is another thing that we see frequently with Down syndrome. And so atresia, meaning you have an atretic section, it did not form, it is missing part of this. And so you will see that there will be, if you're looking at an x-ray, there will be air in the stomach, you will pass through the pylorus, there will be a small amount of air in the duodenum, and then nothing, because there's an atretic section there. So on x-ray, it will look like a double bubble. You will see the bubble of the stomach, the bubble of the duodenum, and nothing else. So double bubble sign is going to look at that duodenal atresia, and you should start thinking, is this a child with Down syndrome? You can see some atlanto-occipital instability as well. You have a widened space between your C1 and your C2 here. When I was going through, in the olden days, we used to x-ray everybody every year to see if there was any atlanto-occipital widening there. Now we do it on a case-by-case basis. If they come in and say, hey, I want to do a sport, a specific sport. Your pants loves to ask this. The child comes in with Down syndrome and they would like to do gymnastics. What is the thing that you need to do? It's always gymnastics on the test question. So if you see that, that's one of the things to look at C1, C2. So what do you need to do? You're like, that is all well and good. I could recognize this on a test question, but what do I do if I have a patient that walks into my exam room, they were just born, and they were like, here, PA, fill in your last name, personalize it. This is your patient. What do I need to do with this patient? So if you have a brand new little baby, first thing you need to do is actually do a karyotype to make sure that you have a child with confirmed Down syndrome. So karyotype to look at all those chromosomes. The hearing screen is going to be particularly important, and even if they pass that hearing screen, so all the other babies got the hearing screen by how many months? 3 months, good. They got the hearing screen. This one, for these children, they need that initial hearing screen. They need another one at 6 months. So that's a slight difference here. They also will need an echocardiogram with cardiology. So every child who has Down syndrome will need that echocardiogram. If they have an ASD, VSD, any other kind of heart defect, you are going to continue to have them see cardiology. If they do not, if their heart is fine, do they need to continue to see cardiology? No. That somehow, that trips up people on every exam. They do not need to see cardiology. In no way, shape, or form is the child just gonna like pop a VSD, right? That doesn't happen. So if their heart is fine, no more cardiology. Don't miss that question. Yes, sir?
Just for the hearing question again, so if they have Down syndrome, it's 0, 3, and 6, or just 0 and 6?
0, 2, 3. So you guys are all gonna learn 0. But yes, that initial one, and then 1 at 6 months.
Okay.
They are going to go to ophthalmology early, so they will have ophthalmology every 6 months to start looking for these early refractive errors and strabismus. They will need to have a CBC done at birth, you need a baseline because they are at risk for certain things. They're precursors again. They have 3 precursors, so they're more likely to have a leukemia. They need a birth baseline of their TSH and free T4, and more likely than other children to have hypothyroidism. Their normal newborn screens and then their regular immunizations. So this is what you would do for that newborn baby. This is what you do if they're not newborns anymore. So, trying to piece this out. So who do they need referrals to? Well, they need that referral for audiology for these ongoing hearings. So it's 0 to 3, 6 months, and then annually for a hearing screen. They're going to need ophthalmology for an annual after those first 0 and then 6 months. They need sleep medicine for questions up until they are 3 to 4, and then they do need a sleep study at 3 to 4. And then the rest of them are, I guess, an early intervention. We have a whole thing where we'll talk about early intervention. It's a federal program that does in-home therapies, speech, occupational, and physical therapy. And then the rest of them are plus minus. So if you have stenotic canals, if you have frequent ear infections, if you have some hearing loss, then you will need ENT for some further management. If you have VSD, ASD, other cardiac complications, you will need cardiology. So those ones are plus minus. If you're going to do gymnastics, wrestling, any of those type of things, you will need those C-spine x-rays for that C1, C2 area. And then everyone will get these annual labs. So annual labs, no matter what, if you have Down syndrome, are going to be your TSH, your CBC, and then your iron studies for those things that you're at higher risk for. The rest of them are questions. So celiac is just going to be questions. And then if you need that, then you will do the lab draw. So celiac is not a lab draw, just questions. The rest of them are annual lab draws. And then obviously your regular immunizations. Of note, I'm not going to put this on there, but and I'm not going to test you on it, but there are a whole bunch of different types of growth charts. So if you put children with Down syndrome on a regular growth chart, they would look like they're failure to thrive every single time. So there are specific growth charts for children with Down syndrome, for kids with Turner syndrome, for kids with Noonan syndrome, for kids with all kinds of different things. So if you have genetic anomalies of certain types of children, then they will have their own growth charts. So Down syndrome has their own growth charts. Your average lifespan is going to usually be between 50 and 55. However, this is plus or minus and dependent on the cardiac. So you have an ASD, VSD, you have any other cardiac complications, your lifespan is going to be decreased. So your determining factor of predicted lifespan is your cardiac. Where are we on time? A couple more minutes before the general comes in and I follow her. That'll be good. Fetal alcohol, or questions on Down syndrome. So what I do need you guys to know is what it looks like, so those phenotypic expressions, and then what sort of health maintenance that you would do for those kids. Those are the things I need you to focus on there. Fetal alcohol syndrome, this one will get you because this will be what is the most preventable type of congenital issue. So this is preventable because we could eliminate alcohol and theoretically this would be completely eliminated. You do see this higher in children in impoverished or foster care situations. So those are just epidemiologically what you see more. There are no labs to confirm this either. So this is all based on your phenotype and your clinical evaluation of this child. So no labs for this one. Same thing, I need you to know these ones, these specific ones, and be able to distinguish this. So the last one for Down syndrome had upslanting palpebral fissures. This time you have short palpebral fissures. So basically from edge to edge of the eye is shortened. So these eyes look proportionately more round because it's kind of squished together a little bit there. The thing that is going to be the most characteristic of this, if you all feel right here on your upper lip, here's your philtrum, and you should feel 2 little bumps. If you don't feel that and it is completely smooth, and you tuck your upper lip in, and you have a smooth philtrum, and basically your upper lip disappears, that is the characteristic for fetal alcohol syndrome. So you have a smooth philtrum and a very, very thin upper lip. Less common, again, some of that flattening of the face, the railroad tracks, so the ears are a little bit underdeveloped. They will have kind of, that's the picture is showing you, you have kind of the dual upper railroad track there. Some microcephaly, some micrognathia, and then you can also have the epicantral folds. But I need you to know the common ones particularly. Just a picture if you prefer learning that way. So this is going to be what you would see. So if you saw these pictures, I think these are the same 4 pictures that have been in every pediatric textbook for I don't even know how long, so great examples for children. But if you look at them, their eyes are relatively round, because they look like they've just been kind of squeezed together, so shortened palpebral fissures. But the biggest thing is that upper lip and the philtrum. Very, very thin upper lip, very, very smooth philtrum. So those are the things to look at for these kids. Otherwise, instead of having a short 5th finger, you have a curved 5th finger. So the clinodactyly, so that is one difference. And then instead of having a transverse palmar crease, you have a hockey stick crease. So that is specific for fetal alcohol syndrome. Both will have some VSD, ASD increase, so that's not going to help you differentiate there. And then the developmental delays are typically what you see. They're a little less intense, but they also will be often the way that this presents. So the times that I have seen this in clinic, we didn't diagnose them as a baby, we didn't diagnose them as a toddler at all. They got to school and teachers were saying, we're having a lot of trouble, ADHD, intellectual disabilities, learning disorders. And so it was the learning concerns from the school that actually prompted a further clinical evaluation that you would get in history. So be aware of those and how it presents, and that to do a full physical exam if that is what is going on. The treatment is then prevention as much as you can. Prevent moms having any kind of alcohol during pregnancy. And then your different types of therapies are going to be the most important. So you're having ADHD treatment for this. Any kind of anxiety is treated with mental health, speech therapy, and then your special education. We'll have a later lecture that talks about all the different types of special education for individual education plans, for 504 plans, that type of thing. Fragile X is one of our structures that we're going to talk about. Super interesting because Fragile X, there's nothing wrong with the X. There's repeat CGGs at the end of the chromosome. And so if you were looking at it on a karyotype, the X itself is not fragile. However, because of extra CGGs, it looks like the chromosome is going to tip over. And so that's why we call it Fragile X. And so Fragile X then, because you have these repeat CGGs, is going to have more likely to have a mild to all the way to severe intellectual disability. This can be one of the genetic causes of an autism spectrum disorder. So one of the things that we see there. So again, you're going to need to be able to differentiate this from a Down syndrome or from fetal alcohol syndrome. So for this on physical exam, these children are going to have very elongated face. So prominent features, prominent jaw, prominent forehead, prominent chin, very large ears, with kind of an elongated face. They'll also have very, very large testicles. So that's going to be one of the most common things that you will see. And then some laxity in their joints, and again with some hypotonia. So hypotonia kind of goes along with most of these, so that's not going to be a super helpful differentiator there. Females, because they have 2 X's, are going to have a much less severe case. So think about this with males most of the time, is who you will see this with. Some of their neurologic features also, you will see ranging from, again, mild intellectual challenges all the way to the stereotypic hand flapping and the severe autism presentation. Your diagnosis you're going to make with DNA amplification, you're trying to look at those extra CGGs. Those are what you're going to look at. Your karyotype is going to show the same amount of numbers. Your FISH is not going to pull out a specific gene that is missing or deleted, so you need to look at DNA amplification to look for excess CGGs on the end. In your treatment, because it's hard to change your chromosomes, you certainly will have genetic counseling, some special education, plus or minus different autism evaluation and therapies depending on the severity level. And then if there's any other secondary things such as seizures, those specialists will be on board. Before we jump into Turner's, we are at the 50-minute mark, so take a break, we'll come back at 2 after the hour. One of the things to think about with this is if you are concerned and you have a diagnosis with autism, you should have Fragile X testing, and then vice versa. So this is one you can work forwards or backwards as a provider, since this is a genetic cause of autism. If you have Fragile X, test for autism. If you have autism, go back and test for Fragile X. So that would just be one of those things that I would recommend to be able to specifically get them that. Okay, Turner syndrome. Turner's, you're gonna hear, so here's where some of my pet peeves start. So you will hear lots of my pet peeves over these blocks. So, when I nerd out on you. Turner syndrome is one of them that drives me bonkers because we talk about all the different types of, Klinefelters that we'll talk about here in a minute. And so when we're talking about 45XO, there is no such thing as an O chromosome. It should just be 45X, right? Because it's either X or a Y. There's no I have an O. That's not an option. So you will see forever 45XO, and it is just 45X. So I just have to pass that on so you can be bothered with me. No reason other than that. Be bothered with me. Get angry with me. So Turner syndrome, 45X. So what is happening in that? So if you're looking at the karyotype over on the side, you literally only have 45. You are missing that second X completely, so 45X. And a lot of times when you have this, you are either, I survive and I do well, or I do not survive. So most children, or most girls who have Turner syndrome, do not survive pregnancy. So the ones that are born are ones of the 5% that survived pregnancy all the way. And then they do typically very, very well from that. For Turner syndrome, the things to think about here in the way that I have always classically thought about a phenotypic child with Turner syndrome is if you took a normal, quote unquote, normal phenotypical girl or woman and then squished her. So if you just squished her and kind of what that would look like, everything would be that. So they're going to be short statured. You squished, then the neck gets kind of wide, so you have a wide webbed neck. Then the chest is kind of squished, and then you have wide set nipples. The face, when it gets squished, it becomes the kind of little triangular faces there. And then if you had early neonates, where you had this lymphedema, so that's what that picture is showing. Think about if you squished a balloon and it just kind of puffed up in those areas. And so that would be what you see in the neonate. So the lymphedema is typically not seen as they get older, but if you had a neonate that was born with that, you should start thinking, oh, I need to do a karyotype on this child. The difference and one of the distinguishing factors is that girls with Turner syndrome are typically developmentally normal, and in fact, they have super superior verbal and kind of spatial processing skills. So they actually are often gifted and talented for some of those reasons, because they have early speech, early problem solving skills. So, but things to look at and make sure that you are aware of for distinguishing this, just think they're squished. I think it's squished, and that should be an easy way to remember that. Oh, I forgot this. I don't know why I threw this in there. This has nothing to do with the lecture, but I thought it was funny. So, does anyone know? Every generation has a blue dog. Who do we have? What's the current generation? Louis. Who was some of y'all's? Because Blue's Clues. My generation. Yeah. And our parents or grandparents. Anyone know that one? Huckleberry Hound. Huckleberry Hound. I meant to put that at the beginning of the lecture. Threw it in here in the middle of Turner, so that's weird. But here we go. Okay, so what happens in with Turners? You only have this one X going on. So things that you need to look at, and I'm going to start with that middle one. So this infertility and amenorrhea. So basically what is happening when you only have one X, you end up with ovarian dysgenesis. So while mom is pregnant, you see a lot of times that these babies are spontaneously aborted. So if you're thinking from a evolutionary perspective, if you are making a progeny that will not have the ability to reproduce, that is where a lot of the time the body will spontaneously abort. You know that this baby will not survive or this baby cannot procreate, the body spontaneously aborts. However, when they make it through that 5%, because they have early ovarian dysgenesis, they will often then functionally come out menopausal. And so that's what you see on phenotype, is that when they hit puberty, they aren't growing like you would expect them to. They aren't starting their period. They're not getting these secondary sex characteristics like you would expect them to, because their ovaries are not getting that signal, and they're getting the signal, but they're not making any estrogen because they're functionally menopausal ovaries, if that makes sense. That is oftentimes how people will present, is they will come for an infertility workup and then walk away with a diagnosis of Turner's. Other things that can go awry. So if you think about this in terms, we talked about Down syndrome has extra genetic material, so those 3 copies. Turner syndrome is missing genetic material, so you only have 1 X copy. So instead of having some of those other endocardial cushion defects, for the heart, you're going to have a bicuspid aorta. You only had enough for those 2 cusps to make. So bicuspid aortic valve. And then early hypertension is associated with this. Think about they're in a menopausal state, so they're going to have early hypertension. So if you had a diagnosis, a known diagnosis of Turner's, this might be the baby that you get a blood pressure on at 1 or 2, instead of starting at the typical age 3, because you have known early hypertension. Some other random renal anomalies, I'm in real trouble with that word today, that you see that will just typically known as a horseshoe kidney. So that 1 horseshoe kidney is something to be aware of. You can also have sometimes 1 kidney, so a unilateral renal dysgenesis. And then endocrine is huge. Because they are not making the appropriate female hormones, potentially, you have often very short, you have, again, that infertility, hypothyroidism, and then osteoporosis. So you basically think little girls in a menopausal state, what are those things going to be? They have kind of that old lady bones with osteoporosis. So early endocrine referrals are going to be super important. Your diagnosis is going to be with that chromosomal analysis, aka a karyotype, to make sure that you only have 45. And then your treatment, so where are you referring? You're referring to endocrine. So endocrine is going to be able to give you those growth hormones to have them grow. And when I say have them grow, we are not trying to get these girls to be WNBA stars. We are trying to get them tall enough that they can reach a gas pedal of a car. We're going to try to get them tall enough that normal counter height is okay for hand washing or for cooking. Right? You're trying to get them into a normal height for daily activities. Estrogen replacement is going to be important, and then hypothyroid, because everything in pediatrics, so thyroid replacement is going to be big there. Similar to Down syndrome, at the time of diagnosis, they do need that screening echo and an EKG. Since, again, think about it, they're those kind of functionally old ladies. So you have the baseline EKG, and that echo to see if you have a bicuspid aortic valve. Your renal ultrasound to see, do you have 2 kidneys, or do you have 1 large horseshoe kidney? And then nephrology if there's anything wrong with the kidneys. So nephrology if there's an abnormality. Klinefelters. So we moved from Turner's over to Klinefelters, so on kind of the exact opposite. We have extra XY material. Klinefelter XXY. Most of the time, they will be normal pre-pubertal. So these are little boys, they have that Y chromosome, that most of the time will look normal. They have some variants, so you could have XXXY, could have XXYYY, could have all kinds of different X's and different Y's. The classic is going to be the XXY though, most of the time, and then obviously in boys. So if you have a little girl on exam and on your test, do not pick Klinefelters. Please do not do that. The way to think about this is exactly like Turner's though, in that these little boys have a testosterone deficiency. So the underlying cause and the reason is very different, but it's some of that same thought process. So you have a testosterone deficiency because you kind of have that extra X. Now that extra X is going against the one Y, and so it's kind of like the two girls ganging up on the one boy, right? One boy's gonna lose. So this testosterone deficiency, or maybe human, I don't know. Whatever. Maybe that's a terrible example. So this one, you're going to have hypogonadism, so very small testicles, as opposed to which one had very large testicles? Fragile X. Yes, so Fragile X, very, very large testicles. Klinefelter's, very, very small testicles. Your infertility does not come from your inability to make sperm, but it comes from the seminiferous tubule function that is lost. So men that have Klinefelter syndrome are able to have children if they pull the sperm directly from the testicles through IVF, but they on their own typically can't because of the seminiferous tubules. This is going to be one of the ways that people will present. Again, they will come to an infertility clinic, and this is what they walk out with the diagnosis of. Interesting, at one of my assignments, this was exactly how somebody presented. They had gotten through a whole Air Force career and had not had the diagnosis made until they were trying to have a child. And so a late 20s, early 30s man was presented here, and this was when sometimes military medicine, you're like, are you kidding me? Because they decided they wanted to MEB this. So it is MEB-able, just out there. But sometimes you, as the provider, will be the first time that this is being diagnosed 30 years later. Right? So that kind of things can definitely happen. Because they have an extra X, there's going to be gynecomastia that will sometimes present in about half of them. And they will have more of a female presentation as far as hair distribution and growth. Sometimes difficult to grow a beard, little or no chest hair, underarm hair, and then have some of that more female build, so a little bit wider hips, can have a more feminine type features. And then sometimes, and typically in a testing case, you will see a lower IQ or some sort of intellectual challenge. You'll see there. Your labs are going to be the same as you would with Turner's, since this is a whole extra chromosome. So you're going to get a chromosomal analysis or karyotype. So you should see 47 instead of 45 with Turner's. You're also going to get the sex hormones. So you will see an increased LH and FSH. So the pituitary is bombing the poor testicles with a signal. So increased LH, FSH. However, you're still having low testosterone. So those are your specific labs that you're seeing with that. Your endocrinologist is going to supplement that testosterone since it is very low. And we have some underlying genetic causes why. But again, that's not going to treat your infertility because it's not that they are not making sperm, it's the seminiferous tubule dysfunction. Interesting, all cases of this are sporadic, so they are not going to pass this on to a child. So the sperm will either be an X or a Y, so all of these, again, sporadic cases. So a father with Klinefelter's is not going to pass this on to young children unless they also have a sporadic case. So just kind of interesting. And then because they have these two X's, and this half of them have a gynecomastia, their risk for breast cancer is significantly higher than other men. So something to be on the lookout for if you have an adult patient with Klinefelter's. A few other genetic syndromes that we will run through. So Marfan's, I was having a discussion about Marfan's yesterday. Marfan's, again, I'm not going to waste a test question on the specific types of autosomal dominant or this or that. It's to be aware that you could see this in females or males because it is autosomal dominant. It is the fibrillin gene on chromosome 15, and please do not spend extra time doing that. The reason that I want you to know fibrillin is that fibrillin is one of the components of any kind of connective tissue. So if you have a connective tissue disorder, anywhere that you have connective tissue in your whole body is going to be at risk for it. having secondary complications with this. So because of that, it's going to have increased areas with increased connective tissue are going to have an increased problem. So skeletal, cardiovascular, even ocular, there's a whole lot of connective tissue in your eye, are going to be specific areas. And that's your little Marfan's man that helps remember everything. So if that's how you study, I love little Marfan's man. Again, no racial or gender preference because this is an autosomal dominant trait. So what are you most worried about? So worried, and things that are going to kill this patient, is if you had a dilated aortic root, because that pressure leaving the heart is the highest right at that aortic root, and so that pressure where that connective tissue can dilate that and eventually dissect that. So that would be the thing that would make them, the thing that you are scared about as a provider is your dilated aortic root that would lead to a secondary aortic dissection. So you're going to try to prevent anything that is going to suddenly increase your pressure. So slowly over time increasing pressure is one thing. A sudden increase in pressure is what you are concerned about. You have a reduced upper and lower body segment, meaning you have really, really long legs and a very short torso. That's what that's going to look like. Very, very long arm span. So you have long arms, long legs, but a very, very short torso, functionally. That's what you're seeing. And then some of our different signs. So rhabdomyopathy that we'll talk about, and some scoliosis, pectus, either carinatum, like a pigeon, or excavatum, like a cave, that you're seeing. And then the lens dislocation. So there's so much connective tissue in the eye that if it is extra mobile, you can see that lens dislocation. So let's see what we got here. Let's look at really what we're talking about with hypermobile joints. So can anyone take, if you're just trying to test this, hand is up and you put it back so you're not trying to leave it, hand is up, and you take your finger and put it to the back part of your wrist. Anybody can do that on either side? No? So that's what we're looking for. So you would have to get a finger to the back portion. So that would be one level of hypermobility. How about if you try to get your thumb down? So not just your thumb touching, but basically like your entire thumb down. Anyone can touch the thumb? No, with that, nobody? Okay. The one that usually will get people is, can you get your finger around your wrist? So a lot of people can get it to touch. The actual diagnostic criteria to get a point here is, can you get a whole knuckle? Can you cross a full knuckle? Dude. 1 point. It's 1 point. It's 1 point. It's no big deal. There's usually somebody, that's usually what people can do. And then the other one is if you put your thumb through the middle, does a whole joint. Does your whole DIP come out the other end? So most of the time, there's a few people that will have this one, but none of the rest of them. If you do, and we want to go through the Marfan's criteria after, it's totally fine. Let me know. It won't even any be. That's what you're looking for that diagnostic criteria. Which one of these is pectus carinatum? B. Yep. And then what is A called? Pectus excavatum. Correct. You have different kinds of scoliosis and kyphosis. If you think about this, that skeletal tissue is trying to hold the body up, and it's kind of funky, so then the bony structures can get a little funky as well. So any kind of lordosis, kyphosis, scoliosis is going to be pretty pronounced, especially if these children are growing very, very rapidly. So they're kind of growing out of their spine in some ways. This is just an example of that upper to lower body segment. So very, very small torso with very, very long arms and legs. So what you're going to do with this one, so this is the first time we've seen this. Your diagnostic confirmation is going to be with a fish study in situ hybridization. And the reason why you can do this is because it's just one gene. So if you did a karyotype, they have all the chromosomes. If you did DNA amplification, there's nothing that's amplified there. There's nothing extra. There's a mutation in one gene. And so you're looking for this to hybridize to that one gene that is the abnormality. Things that you're going to want to do to make sure you get these children to the right areas. So cardiology is going to be one of the places. You need a baseline echo. You need to see, is there any aortic root dilation from the get-go? And then potentially if there's valvular insufficiency, we need endocarditis prophylaxis. The other thing that you're going to want to do is making sure that you're not going to get that pressure happening very, very quickly. So your pressure differentiation you don't want. So things like if you want to do, like, for example, I had a patient, cardiologist was totally fine with them doing cross country. So they could run cross country where there was long warm-ups and they had sustained heart rates for long distance runs. They were totally fine with that. What they weren't fine with was weightlifting and roller coasters, right? You don't want anything where they're going to be pulling G's, basically. So no roller coasters, and then no weightlifting where you had that sudden valsalva and that sudden increase in pressure. And then evaluation yearly for scoliosis and ophthalmologic evaluations for any kind of problems there. It will typically have some refractive errors because that has some connective tissue in it as well. With this, I will just say too, this is kind of interesting, not going to make you learn the diagnostic criteria. I think I put it in there, but it's a hidden slide. But if you have that, it's just like Billy Tool, so you can literally go online and say, okay, you're going to point for this, you're going to point for that, you're going to point for this, you're going to point for scoliosis. Okay, I have this many points with this many criteria. What do I do with this child? So, whole diagnostic criteria out there with how to do that. So, if you love pediatrics and genetics and you want to do that, well, we can do that all day long in all your spare time. DeGeorge syndrome. This is a couple of more. So we will call this one multiple different names. Villocardio-facial syndrome is another word for it. If you hear catch-22, that is going to be another name. The reason being is that it is a deletion. So you have a deleted section of chromosome 22. So it's 22 and then 11.2. But 22, there's just a little bit of genetic material that was missing. What is super interesting about that is that little bit of embryonic tissue, or a little bit of the deletion, is then a deleted part of your embryonic tissue, so it doesn't make your branchial cleft. And the only reason that's interesting is because that is going to make your midline structures. So anything in the midline is what you're concerned about, because you're missing that little section. And so anything that you're thinking, hey, if I just kind of drew a section around here, what runs through there, because I'm probably going to have problems with that because it didn't form, didn't have the genetic material to form. So what's in the midline here in the chest? Well, your heart. So you have some sort of cardiac abnormality. Your face is midline, so oftentimes you have some facial abnormalities. Your thymus for a child is right in the midline, so you can have a complete absence of that. Cleft lip, cleft palate. And then hypocalcemia, really you can see any of these pituitary things because your pituitary is midline as well. So that's why we call it catch, and catch-22, again, your deletion in that small amount of chromosome 22. Brief on that. Williams syndrome, one of my personal favorites. They call this the cocktail personality. So instead of a deletion of 22, you have a deletion on 7. Again, I'm not going to waste your test questions with a deletion of what gene, but just to be aware that is part of that. So what this one and this one specifically, to pair these words up, supravalvular aortic stenosis. So you can have 3 different places where the aortic valve can stenose. It can be at the valve itself, where it can just be really stenotic. It can be above the valve, can be stenotic, or you can have subvalvular. So this one is specific, is supravalvular aortic stenosis. Goes with Williams syndrome. These little kiddos are very, very short, but they are very, very personable. And so one of the ways that they'll call them is Elfian-like as well. They're the happiest children in the whole world. They come into clinic and it's literally like Elf came in. They're so happy to be there. Cocktail personality, everyone's best friend. And they're these teeny tiny little kids. So very, very small. So that's why they've been given those cocktail personality or Elfian-like personality. This one will try to get you confused then with DeGeorge syndrome with the calcium. So they're not missing those midline structures. they in fact have hypercalcemia. And so another thing to think about with the supravalvular aortic stenosis, they don't correlate, but it's just how I remembered it, is that it was the calcium that went and made the aorta stenotic. So just remember that. That's not actually what happens, but it just is what helped my brain remember. A few of them will have an autism-like personality as well, so something to think about there. And then I think this one is one of the last one. Prader-Willi syndrome. So, do you guys have genetics at all? Does anyone know what imprinting is? Imprinting syndrome? So, what happens with imprinting disorders is if you get a copy from one parent, it looks like one type of syndrome. If you get that same copy from another parent, even at that same genetic place, it looks like something else. So you can have two completely separate syndromes depending on which side imprinted and which one is the phenotypic presentation. So it's an imprinting disorder. So that's one of those specific things to know about that one. And it's super interesting because they come out one way as babies, and then they grow up and it's completely different. So they come out small, puny, hypotonic, difficulty feeding, failure to thrive, growth delays, just these teeny tiny little kids. And then what happens as they get older is they basically have no mechanism that tells them with the leptin and ghrelin cycles in their GI system that they're full. So they never get the signal that they are full. And suddenly they have this just insatiable appetite and they will eat all the time. When I say all the time, these are families that literally have to lock up pantries, lock up refrigerators, lock food because they will just continue to eat and they will eat themselves to death. Okay, so start off one way and they end up completely different as they get older. They also have a whole lot of endocrine problems, so hypogonadotrophic hypogonadism. So they don't have the HPA access telling them, and thus the gonads will end up shrinking. Some delays with some developmental things, and then very, very small features. So very, very large children with very small hands and feet. Okay, so a super interesting one. So this one, just extra for you. It's chromosome 15. This is from mom. From dad, if you got the same thing, you would end up with Angelman syndrome. So just super interesting how this does it. So I will nerd out about that all day. I won't though. So a couple of checks. The 3-year-old male is brought in by his adoptive parents. I'm going to stop there. If you ever see adoptive parents or adoptive child, they're trying to tell you it's something genetic. So if you see anything like that on the pants, it's something genetic or something that we could have prevented. So you know it's vaccine related, it's genetic related, chromosomal related, something to that effect. So 3-year-old brought in by adoptive parents for his first well child check. Family history is unknown. Which of the following physical exam findings would suggest fetal alcohol syndrome? D, your smooth philtrum, right? What are you looking at for small for age testes? Klinefelters, yep. What are you looking for? Up slanting palpebral fissures. Down syndrome, yep. What are you looking at for breast development? Who's got abnormal breast development? Klinefelters, good. Does anyone know this? Hemihyperplasia. It's not even in this lecture. It's that quick way to move. That's me just me. Yes, sir.
Is the breast development, would we expect that at 3 years old, or would we expect that as a teenager?
You would expect it older. Yeah. So that's why this is a terrible question. Don't pick this because yes, you would see it in an older patient. So those are the ones that we talked about. Wow, I'm finishing. Questions, comments, concerns, anxieties, frustrations, griefs, miscellaneous toxicities. None. Great. Okay, have a fantastic